Good afternoon, everyone. My name is Anugrah William, and on behalf of HPI, FICCI, NATHEALTH, I welcome you all to the GST Workshop, Unlocking Embedded Credit. To discuss this in detail, we have organized this workshop, and I'm happy to introduce and welcome the experts who have joined us here today. Dr. RANJAN CHOUDHURY, Advisor at CT Division, National Health System Resource Center, NHSRC, Mr. Naveen Kumar, Special Secretary Health, Government of Andhra Pradesh, Mr. V.S. Krishnan, National Leader, Tax and Economic Policy Group, Policy Expert, Ernst & Young, EY. Before we start, I would like to make some housekeeping announcements. For our audience, please use the Q&A function on the bar at the bottom of your screen to type in your questions. The moderators will be able to see and address them. Please do mention whom your question is addressed to. Now for the opening remarks, I would like to request Mr. Rupak Barua and Dr. Harsh Mahajan to say a few words, please. Over to you, Mr. Barua.
Yeah, good afternoon, everyone. Good afternoon, Anugrah. And see, it gives me great pleasure and honor to welcome all of you here. This session, this is one of the most important session in the recent time, because the GST Council meeting, the Council actually has announced that there will be the first time there will be the 5% GST they are going to apply to your healthcare hospitals, the bed charges. 5% over and above that 5,000 bed charges, and other than they have excluded the critical care beds. So that is the whole discussion here. Now this you know all that healthcare we are struggling. The whole healthcare sector, whole care segment, actually we are struggling, and making it's an affordable healthcare at an the accessible healthcare at an affordable price. Now the question here is that whatever your GST and all implication is there is a direct that we'll have to realize from the patient. So what is ultimate, what will happen? That is out of the implications, there is particularly the middle class citizens actually will have better, a much larger kind of an impact, because 62% of the total the out-of-pocket expenses still in India of the highest, and it is going to impact a lot to the private your middle class segment. Now healthcare is not a luxury, this is not by choice. So whenever they opt for your private healthcare, we all understand that because of the quality and maybe to some extent of some convenience, actually they opt for your private healthcare, the general. Now this is one part, and the other part, if we see here, that GST, the other side, that is according to this is the NatHealth, there's and EY, there is a study, they had a detailed study actually. And that's the other part also, that the healthcare service segment, they can get some kind of a benefit out of the embedded taxes, if that is at all any. And as per the GST law, actually, it will be refundable, and that the healthcare sector segment can use it for a better infrastructure care and more civil and the capital infrastructure. That is the other part. So it's to understand more, there are the experts available here. That's a very, very important discussion, because way forward in future, actually, all our operations, the financial condition of the hospital will depend a lot on your GST implications. So we need everyone, whoever they are in this panel here, they are going to deliver you the most expert comment about this GST, how you are going to get benefit, and what are the implications to the common people is going to happen. So great opportunity for all of us to understand, and I look forward for great discussions ahead. Thank you so much.
Thank you so much, Mr. Barua, for your opening remarks. I'll request Dr. Mahajan to come in, please, and say a few words.
Thank you very much. It's an honor and a pleasure for me to welcome all of you to this educational exercise. We need to learn from each other, and we need to actually see that the ultimate beneficiary, the patient, is the one who is able to get healthcare at affordable prices without any compromise of quality. And that is what this exercise is about. As most of you will know, the healthcare sector and the providers, the hospitals, the diagnostic centers, the labs, for them, it is in a GST exempt category, which means when we charge for a test or for a surgery or for a procedure, the patient does not need to pay any GST on the bill. The healthcare sector providers have been exempted from GST, from levying any GST. On the other hand, everything that we buy, whether we rent a building in which we house a hospital or a diagnostic center, whether we buy our machinery, we buy consumables, anything we buy, we have to pay GST. In other industries, what happens, whatever GST they pay, they are able to get ITC back. This is input tax credit back, and that to a larger or smaller extent offsets the GST they have paid. Whereas in the provider sector, what happens is that we are paying the GST and getting nothing back. The EY study, which Mr. Barua just referred to, showed that probably the healthcare sector is the only sector where, based on what taxes we were paying before the GST regime, actually the taxes have increased. We are paying nearly 1.5 to 2% more than what we were paying earlier. And this was one major element which came out of the EY study along with NatHealth. So while the context today may be the 5% GST that has been charged, what we have been requesting the government over the last 4 years is that kindly, instead of keeping healthcare into an exempt category, bring it into a zero category, zero tax category, which will not in any way impact the patients. They will still have to pay whatever they were paying earlier, but it will help the providers, the hospitals, the diagnostic centers, the labs, that coming from exempt into zero category, we will be able to actually get input tax credit back, which currently is about 5.5 to 6%, which is embedded tax, which we are not able to touch at all. If we were able to get this back, we may be able to lower charges which the patient has to pay, because we will get something back in form of ITC. With this 5%, actually the government has mandated that we will still not get any input tax credit back. And I think without taking much more time, the deliberations of today are going to be, I think, in a very positive frame of mind, trying to find solutions rather than doing finger pointing. So, because ultimately, if the healthcare sector is not viable, we will have to increase prices. Who pays those prices? Ultimately, it is the patient who pays prices. And so what we want is something which is win-win for everyone in this space, be it the government, be it the private healthcare providers, and most importantly, the patient. So thank you very much. I will wish this workshop all success, and I'm sure the deliberations will come out with certain solutions which we can present to the government to further our cause. Thank you very much.
Thank you. Thank you so much, Dr. Mahajan. Thank you for your guidance as always. I will now request and mention about the discussions which we are going to move on. I would like to invite Ms. Shambhavi Sharan, Senior Consultant, Tax and Economic Policy Group, Ernst & Young, who will be moderating this session with the experts. Shambhavi, over to you. Thank you.
Thanks, Anugrah, for the very warm welcome, and a very warm welcome to the distinguished panelists and the thought leaders present in the discussion today. Dr. Mahajan has very nicely and in much detail explained the issue faced by the healthcare sector in the GST domain. And to get started on this discussion, I would like to invite Mr. Krishnan, who was an ex-member of the Central Board of Excise and Customs, to provide us the principles and history behind GST and how it has evolved in the healthcare sector, and what are the problems faced by the sector with the present GST regime. Over to you, Mr. Krishnan.
Thank you, Shambhavi. First of all, I must compliment Dr. Mahajan, who has very lucidly explained the issues, although he's not a tax expert, but it very lucidly has explained the whole issue, all the issues. What I would like to mention first of all is that what is the basic principles of the GST scheme? Because once we understand the principles of the GST, then we can understand better the policy implications of various government decisions. Prior to the introduction of the GST, the value chain from raw material to retail was fractured for the purpose of taxation. The value chain up to manufacturing was taxed by the center, and the post-manufacturing value addition was taxed by the states. This fractured taxation disrupted the value chain and prevented a free flow of credit. Now, what the GST did was it integrated the entire value chain and brought them under the what is called a dual GST, in which both the center and the state tax the entire value chain from raw material to retail. But for the GST to work effectively, it is important that the flow of credit is ensured across the value chain. And for that, any exemption creates a problem and disrupts the chain, which is why we say that in the GST scheme, an exemption is a problem, not a panacea. So, so that is the whole idea. And Mr. Mahajan also talked about the distinction, talked about zero rate and exemption. The distinction is that in an exemption, you don't get the tax credit and they get embedded. In a zero rating scheme, you get the input credit back. But the current government policy is not to have zero credit except for exports. No commodity in the scheme today has a zero rating. So I'll stop here with these words and then maybe elaborate on the study a little later.
Thank you, Mr. Krishnan. I would like to now call upon Dr. Choudhury to provide his initial remarks and viewpoint on GST healthcare. Dr. Choudhury, please.
Okay, good afternoon to the panelists and all other members. Thank you for inviting me and giving me the opportunity to share my ideas. I had a meeting with the NATHEALTH, Mr. Siddharth, on this GST issues, and had attended one conference earlier also, workshop. So what my limited understanding says, this is a problem. This is a problem. Why? Because we don't have a uniform, GST as per the value chain in the healthcare industry. So people are not about there were a lot of proposals coming with a high input, the taxes and output, and the finished goods, they don't have that similar tax rate. And whenever there is an exception, that chain breaks down. So it's very lucidly explained by Dr. Mahajan and Dr. Krishnan. So my initial thoughts will be, basically the government has formed a group of ministers, and these group of ministers, they make the recommendation, and as you are all aware, the GST Council sits 6 months and they deliberate on all these issues. So their main issues will be, how the hospitals will pass the benefit to the consumer, like the patients. That's the first question. And how to control the profiteering by the hospitals. These are the two important questions which always is in the mind of the government. And the interventions, if I say, basically to achieve the universal health care, we have to lower the out-of-pocket expenditure of the common man. That means all services should be free. If I say in a country, in future, we have the goal that all citizens in the country avail free services, healthcare services at least. So in this context, the out-of-pocket expenditure is gradually reducing. It's a good sign. If you see the NFHS 5 and all, it's now pegged at around 47.5%. Earlier it was high, and there are a lot of government initiatives how to reduce this out-of-pocket expenditure, like promoting generic medicines instead of branded medicines, if I can say. Then also for increasing the availability of the medicines by through bulk procurement, like medical service corporations have come up, and where the competitive bidding is there. So obviously, if the value is less, your GST impact will be also less. So there are two issues. One is the business, where they spend money and pay to the government on the raw materials and all. They should get it back on the finished good. That is one issue. And the second issue is when we have a common man going, he should not pay more. Now the insured health, like the recent news, the 47th GST Council, I think they have made 5,000 rupees and above under the GST, the room rent. Now this is going to affect, definitely, as Dr. Mahajan had said, the people who are insured, they will not be coming under this, because their expenses will be paid. But there will be 40 million people or more, I think, who are uninsured. So it is going to affect them. And rightly said, the middle class, the sector, where you go to the hospital and you don't know how long you have to stay, and you take a room, good room. So either the person who is admitted and he requires treatment, his bills are definitely going to be little inflated. So I'm not aware whether this hospital room rent, when they are passed a GST, are they able to get that ITC, what was being discussed. So the initial thoughts, however, stays like for the government, yes, the GST Council is the right forum where the issues should be taken. And they are the right person whom, the group of ministers who should be made aware, because it comes under the finance ministry directly, like Dr. Krishnan has said. And they have to understand that the entire value chain should be such seamless and smooth, where the manufacturer, while manufacturing the unfinished things and goods and delivering to the healthcare sector, if they are incurring the cost, they should be allowed to, get the ITC. I'll stop here. Thank you.
Thank you, Dr. Chaudhary, for your remarks, and specifically for highlighting the issue of high out-of-pocket expenditures, which is a key concern and the guiding issue for all healthcare policy these days. And we have with us also the Special Secretary, Mr. Kumar, with us, and I would like to request him to provide his initial remarks on this subject, and perhaps also provide the state perspective on the same. Thank you.
Yeah, thank you for this introduction. See, I would only start at the outset. I should also admit that I'm not an expert in GST and how it goes. I think the way Krishnan sir mentioned, the philosophy of the GST is to not to have repeated taxes. I think that's the fundamental, if you want to put it in the layman terms, I think if you have paid tax once, and then it should be this thing. I think that's the question both the introductory speakers were making, saying that whether they should go for zero rate or embedded, or that's a question. I think the way you represent that question is to show by numbers. I think the EY had already done a study to show by numbers this is what would happen. But I'll go to the general picture of healthcare as such, because as all the speakers have admitted that from the 2019 data, we see 62% is the out-of-pocket expenditure. And when I say out-of-pocket expenditure, we are clubbing all medical services. It's not just a particular group of, because when we try to do this healthcare as a unit, I don't think healthcare should be treated as a single unit. Rather, it should be treated into multiple segments also. I think that's very, very important. If I'm going to ask you a question saying what is the out-of-pocket expenditure for tertiary care, I remember when we were working on the cancer care, we were trying to find out what is the out-of-pocket expenditure for cancer. So this could be very well beyond 100% also. It could be 150% also. This is a serious cause of concern, which we should admit. I think that's the way we should look at not just healthcare as a single, a platform or a single continuum. Rather, we should look at segments within the continuum. And we also look at, for example, I'll put my state perspective, 87% of the people avail cancer care outside the government setup, which means it could be phenomenally 150 to 200% of out-of-pocket expenditure, which could really happen. We only provide for a small number of 13% of people at the government, setup. So which means that the 5,000 rupees, when we tax those people who are above 5,000 per stay or something, this would also have a cumulative effect on this thing. So I think when EY or the experts are doing study, they should also look at this factor. How do we look at this particular aspect of reducing the load on the patient in a bigger way? I think the last speaker was put it quite I think I would call it's in a political way of looking at things, that are you sure if you are going to reduce GST, if you remove this 5% bandage or 0% rate, will you transfer the benefits to the patient or not? That's the confidence the system has to put in. I think the healthcare, the NATHEALTH or somebody should drive this point. We should infuse that confidence into the system, saying, okay, the reason I think it has been taxed is that it's been noticed that the benefit is not transferred to the patient at large. That's the reason maybe it's taxed. So I think that's the confidence the NATHEALTH and the others should build into the system, saying, okay, if you give us this exemption, we are going to transfer this benefit to the citizen, the patient at large. This would bring the confidence in the system, and I think any government would be happy to do it in case they would probably take a relook at things. As I think this is very, very important concern, that there is a direct connection between GST and the out-of-pocket expenditure. This establishment of this fact with more numbers, looking at each of the super specialties or the specialty, super specialty, we are also looking at smaller this thing. So there's also, we calculated for one of the chemotherapy thing. In fact, and if you ask many of the people, they'll tell you 5% is smaller loss, right? If you look at there are systematic changes even within the healthcare which they can bring in. Like the previous speaker was making this remark, why can't we move to generic drug? It also looks at the bigger picture of managing the entire healthcare rather than GST part of it. I think if you want to transfer benefits to the public at large, the hospitals, the private hospitals, and all of them should come into a significant way to reduce the procurement, increase the operational efficiencies, so that these benefits can be easily transferred. I don't think GST is the only problem here. There's also a bigger problem. If you talk about the other things are also concerned here, so we should also look at that point. It's not just that GST which is going to create this problem. Yes, GST will have a cyclic effect on the already existing high OOP, but we can also transfer benefits. Like it was excellent, the previous speaker made this remark, procurement and moving to generics, which also give that benefit. Do we transfer these benefits to the patient or not? For example, we go to an hospital, there are patients who would opt to take a generic medicine, did the cost of treatment go down or not? Is there a study to show that? These are things we should look at. Thank you.
Thank you, Mr. Kumar, for your excellent remarks, and especially highlighting the point that the benefits have to be transferred to the patients at the end of the day. And here I would like to actually invite Mr. Krishnan to discuss this study and what were the key findings of the study, the level of embedded taxes faced by hospitals, and what are the ways out of the situation? What are the policy recommendations we should consider?
So
Mr.
thank you.
Krishnan, please.
Yeah, thank you, Shambhavi. I think I'll get to now specifics so that we can put forward actual policy suggestions which we can go to the government. What the study shows is that there's about embedded taxes of about 5.5 to 6% in the healthcare system, which loads the costs. So that is something. And second, we pointed out also that the embedded costs have increased post GST compared to pre GST, because pre GST there was a limited pass through of the VAT taxes to the goods component of the healthcare services. Therefore, this is one segment where, in fact, the embedded taxes has actually increased. So, what are the concrete policy options which flow from that? Our suggestion was that because government is not inclined to zero rate, so we suggested that one way is to have a merit rate of duty, whatever it is, 5% now, on healthcare services, and it could be with private healthcare, to start with private hospitals and private diagnostics, and government hospitals and government diagnostic centers could be given an option to either come into the 5% or not, and that option should be exercised at the beginning of the year. So that is the first suggestion. Second is, because a lot of the government segment will be outside, like the primary health centers, district hospitals are outside the GST net. There is also a case to lower the value chain which feeds into the healthcare system. For example, medicines today are at 12%. There is a case for bringing all medicines to a merit rate of 5%. This will benefit the government sector, which is outside the GST net. And the second is to bring medical devices also at the merit rate. Most of them carry a GST rate of 12% and 18%. If you bring both medical devices and medicines at a merit rate, then the entire costs into the government sector will also benefit from the lower costs. And what I think the medical devices and diagnostics systems are especially important, because I think preventive healthcare is more cost effective than curative healthcare. Because, if you can diagnose something earlier, the cost of treating it are much less. So what we need to build here is a very sound and low cost medical devices, medical diagnostic industrial base. And here what my own suggestion is that the government's PLI scheme now is limited to a few items. That should be extended to a lot of these diagnostic devices. And to start with, at least these diagnostic devices which are in the under the PLI scheme could carry a merit rate of duty, so that the demand base can be enhanced, and that would help to support a vibrant domestic industry. Finally, I would also suggest that there is a National Innovation Fund which has been created, which could also be used to bring down the costs of domestic diagnostic equipments, because I think this segment can really contribute to helping preventive healthcare, and a lot of our primary health centers and our district hospitals can benefit. I'll leave it at that.
Thank you, Mr. Krishnan. I would like to invite Dr. Choudhury to provide his remarks on these various options, on the feasibility and the government perspective towards these various options to solve the issue of embedded taxes.
Thank you very much, but I'm not a GST expert. very well said. We have all listened to Dr. Krishnan speaking so nicely about the importance of having merit tax. But I also agree and believe that yes, if a manufacturer is spending some money and he is not getting that tax, credit, then he'll be demotivated. See, in order to encourage the manufacturing sector and the medical devices and other, I'm sure there is provision of ITC for them. But in the value chain, when it is, these devices are being used or diagnostics and in vitro diagnostics are used and the lab, we find that the taxes and all what the finished good attract is not able to get the ITC. That is the actual per se, but it's a complicated, it's not so simple what we just now heard. So it is a better, these options are dealt with financial people and the consultants and the specialists from the GST departments, because the mandate for lowering this is not with the health sector. We can only recommend or say agreement, but the GST council and the group of ministers who are recommending, they are the right people who have to understand, because they are also, quite learned people sitting there working on these issues. So as Dr. Krishna has mentioned, a very nice proposal they have given. Government, public health sectors and all, there is a choice whether they will take or not, very rightly said. And the private hospitals, they start off having a merit-based tax. And it should be discussed at length with the GST council in an appropriate, either they should be, invited or a delegation. I will request the NATHEALTH to, visit them and talk about this and at least take their view, what they want to say, what is their view. Then only we can understand, because me speaking and sending a proposal doesn't have any weightage. We have to understand the other side. Why the group of ministers, why the GST councils and all, after deliberation and initially I read somewhere the inverted the duty structure, it is beneficial for the government. I don't know how it is beneficial. And we talk about correcting the inverted structure. So might be they have some instruments like capping certain costs, so that every the cost does not escalate. Like I'll give you an example of the CAPD fluids. They are capped, the implants, the stents. So these government has resorted when there is a wide disparity of the cost. So in order to check profiteering, they have used this instrument for capping. There's a NPPA, National Pharmacology or Pricing Agency. So there also people should be represented. They should be also consulted. We should take their feedback. So once their feedbacks, and actually what is the issue which the government is not giving us our understanding about entire merit-based structure, which is a very good proposal. So we should be able to impress, yes, this will help us, and it will help us to pass the benefits to the patient who are actually availing. So whether this will improve or increase the competitiveness in the market, that is also a one question which a study has to be done. Rightly, my previous speaker also mentioned about that. So if we have certain facts and figures, and then it's been deliberated and spoken with the GST council, I think we can make some headway. So that's my initial opinion. Thank you.
Thank you, sir. I would like to invite Mr. Kumar now to give his opinion on the various options presented to solve the embedded taxes problem.
Yeah, see, what I would say is, when you have consumables used in the treatment, these consumables also, I think there should be a study. I think probably there should be a study user-wise also. For example, we are looking at cataract operations, right? So that is one operation which would affect the general population at large. That is, maybe 20% of the population would need cataract surgeries. So these are items which I think the government should look at the GST Council should look at a different view. So we should also, broad base, put numbers like the previous speaker would actually to bring facts and figures. I think that's the fundamental thing to make your case clearly before the GST Council. The case is like, these are the number of cataract surgeries which would happen. These are the population group. This is the social economic status of this population group. And this would be the effect on those population group, right? So you should also, that's what when I opened my speech, I was actually mentioning this. Healthcare should be broken into many components, and it has to be re-looked into a different format. Who goes to where for which treatment? For example, if I ask you a question, how many beds would be less than 5,000? How many beds in the country, hospital beds, would cost more than 5,000? Okay, so that's one question we should look at. Maybe all emergency beds would cost more than 5,000, right? So, for example, even COVID, some critical cases. So we should also look at numbers. How many numbers would move? For example, if you look at the patterns in COVID treatment, so you would have 2% of the cases moving to, critical ICU care. So there, I think we must also seen there were some COVID patients who had to shell out 1 crore, 2 crore for their treatment. So it could be a poor person. So the COVID doesn't distinguish between a poor person or a rich person, right? So we should also look at that particular aspect of putting those numbers. I think that's how when you make a case before the GST Council, these numbers have to be clearly put. This is the number of people who would need, out of which we always assume that only the poor or the rich only affords all this treatment. Even the poor also is able to afford those kind of treatment, because we have excellent medical insurance scheme within the government. In fact, Andhra Pradesh government is the largest provider of medical insurance. We shells out around 3,000 crores of medical insurance money. 3,000 crores. I think it's way beyond any other state which is in the public health sector. So this is also very, very critical component. If medical insurance is protected, or the person is protected by the medical insurance, it is also the load on the government. In case the patient from Andhra is getting a treatment in cancer, the government of Andhra is going to pay for it. So anyways, it comes back to the government only. So these are the numbers, clearly have to be understood, put it in a very detailed form, and that will make the case better.
Thank you, sir. Before we actually move on to the questions raised by the audience, I would like to request Mr. Krishnan, if you would like to respond to the various aspects that were raised by Dr. Choudhury and Mr. Kumar on the inverted duty, on insurances. We would like to understand your views, sir.
Actually, there is a fundamental issue. You see, the 15th Finance Commission made the point that prior to the implementation of the GST, the average incidence of duty was 14.8%. Post GST, this incidence has come down to 11.8%, which means there has been a 3 percentage point decline in incidence, and this has affected government revenues. So the 15th Finance Commission mentioned that any rate rationalization done by the government should keep in mind the fact that the GST was intended to be a revenue neutral exercise, not a revenue depleting exercise. So when, for example, so that is why the recommendations of the Bommai committee, which is likely to come in 3 months' time, is extremely important. So when we say that, look, there was a GST committee report which was submitted in 2015 before the GST was implemented, which mentioned that medicines and clothing and other items should be placed at the merit rate. So what we are looking at is a 3-rate structure now. Now we have, for example, we have exemptions, we have 5%, we have 12%, we have 18%, we have 28%. So the idea is to move towards a 3-rate structure, a merit rate, which could be 8 instead of 5, a standard rate, which it's 18% now. The question is whether it should be 16% and then you make it up somewhere else. And there is a demerit rate of 28%. So point is, when I suggested that, that medicines and medical devices could be brought to at a merit rate, because this will benefit all the government sector, because especially the Jan Aushadhi scheme. For example, this will reduce the procurement costs of government because government is procuring medicines. So the whole ecosystem for healthcare should be looked at in a holistic manner. For example, there was a lot of discussion in the press about the 5% rate of duty on hospital rooms. And then the response of the government was that 5,000 rupees hospital room is fine because it is used by the rich. I think the rich-poor argument is not relevant here. The point that was being made is that the levy of 5% on hospital rooms went against the very design of the GST, which required that duty is levied on every segment in the value chain. Now, if GST healthcare is exempt and you levy duty on hospital rooms, which feeds into the healthcare, then you have an embedded tax. So hospital rooms cannot neither use the input credit, nor can the tax be offset against the healthcare costs. And when you are phasing away exemptions, which is good, a distinction must be made between phasing away of exemptions of final products and phasing away of exemptions of intermediate products. The mistake done is that, while phasing of final products is fine, rooms are an intermediate service going into healthcare services. So by only taking out one segment, you increase the embedded taxes, which was not the intention of the government. So the point that was being made is, when you look at GST rate rationalization, look at it in a holistic manner, look at the whole value chain, ensure that every stage duty is paid and at every stage it is offset. That was the general point. So there are ways in which government can raise revenues. It can raise a number of things. The 12% rate can be integrated with the standard rate. Exemptions, there are about 300, 400 exemptions. They can be phased away. So there are many ways in which, despite reducing the duty on medicines and medical devices, you can still increase the revenue by raising it in other segments. Thank you.
Thank you, sir. Would Dr. Choudhury or Mr. Kumar like to give their views on the rent, the recent rate of 5% that has been put on the rents of hospital rooms?
So I would clearly agree with Krishnan sir for this thing. I think that's what we had to go back to the fundamental philosophy of putting. I think he was very clearly has put it in layman terms. Fundamental philosophy of putting the GST, right? So if you look at it, we should not have multiple taxes, and if there's a one-way rule to it, the same rule should be followed across the sector. I think that he made it very clear. I don't think it needs more explanation. I think he made it very clear. So I think it's, again, I would suggest that we should put numbers and explain why this happened and what would be the effect of this. I think instead of waiting for the effects to fall in, I think there's always a way to show that this would have some effects of it.
Very rightly said, Mr. Kumar. Dr. Choudhury, would you like to add?
Yeah, I fully agree with my previous speaker and Dr. Krishnan. Government has been, right now in this 47th recommendation, GST Council meeting recommendation, they have reduced, I think, the GST of ortho implants or something. So these, they are taking the exercise in patchy manners, pocketed and doing something reduction. So very important thing what Dr. Krishnan has said that, there are around 300 to 400 exemptions which requires to be phased away. And so we have to do a study. What are these exemptions, how they are impacting the out-of-pocket expenditure of the common person. And of course, the point is valid. The rooms rent and all that is an intermediate, is not the finished product. In case you are making the, you are promoting ambulatory healthcare service rather than the, hospital IPD indirectly. So a patient who is in emergency, he will require admission. He has to stay in the hospital. So, by increasing the cost of staying, it is contrary to the, government's own commitment of, making the healthcare affordable and accessible. So it requires to be corrected. I fully agree about that. Secondly, the question of, what should be the best figure, that is again debatable. Uh, as he's rightly said, whether it may be 5% or 8% or something. So this requires a lot of negotiation, discussions, and after a study to have, if we have a merit-based tax in the value chain and how it's going to impact and what all things will come down. This study requires to be done with facts and figures. Then only a strong case, a watertight case may be formed for going to the GST Council and asking for their opinion and views. Thank you. Thank you.
Thank you, Dr. Chaudhary. We have another audience question with us to the panel. How do we bring into ambit pieces of healthcare like senior care and home care? Mr. Krishnan, would you like to talk about home care and how that could be brought under GST? It is already under GST, but should we be looking at exemptions?
See, home care, what the COVID crisis brought out very clearly was the importance of home care services. Today, only those healthcare services are exempt, which are clinical in nature, fully established. Home care services is a loose area, and it is paying duty now. So there is a case for carving out specific segments of home care and bring them under the merit rate. For example, a carve out for cancer care, a carve out for renal health care. So, but where you do the carving out, you have to establish that there is a specialized kind of the nursing professionals who are going to do this, and the clinical nature and the standards that are being observed must be clearly demonstrated in order to get the merit rate.
Right, sir. Would Dr. Chaudhary like to provide his inputs?
Yes, I fully agree with what Mr. Krishnan says. And being a doctor myself, I fully agree that the COVID times has taught us, these are the lessons learned, that home care is coming up and is more preferable, I'll say. Initial days, if you go through the history, earlier a patient would require proper drug treatment. They were called sanatoriums, and these sanatoriums in hill stations and all that concept now gradually it waved off. Then we had the concept of hospitalization. Now we have the concept of ambulatory care. Okay, is the OPD care. Basically, people would not like to stay in the hospital due to various reasons like hospital acquired infections and all. And now the concept is more so a home-based care. Initially for small, we have been also deliberating here, for the emergencies to be managed, the home-based care becomes slightly difficult because a person himself, the self-care, the self-testing, or, the service provider providing the services in home. There is a fine touch about a personal judgment when he should report to a healthcare facility. So rightly said, we must have, particular cases like chronic illness cases as mentioned by cancer care, palliative cares. These segments would require the elderly care. They require the home-based care. They are more into this. And we should be asking for whether, I'm not aware that, but Dr. Krishnan said there is a GST on the home-based care services. So it should include a merit care because these services are basically for the poor, for the people at the home, and it should be defined well. There are yet no standard, protocols or a validation protocol or a policy wherein you can check what is going and what should be done and how much of this treatment, because there is a judgmental issue when the patient will be brought to the emergency or to the hospital. So this is a very important point, and I think it will be streamlined in the days ahead. And this home-based care, the care is going to stay in the future, and it will be strengthened with good governance and policy. So importance is to have good checks and balances so that no patient dies. The patient safety is not compromised. Thank you.
Absolutely, sir. I'd like to request Mr. Kumar also to provide his.
So I
inputs.
think both the speakers could put it. One is that we are already taxing home care, and the previous speaker, Dr. Choudhury, was able to tell us how we were moving from the ambulatory services to the home care. So we also had to look at the disease pattern. I think Dr. Choudhury would agree with me that the disease pattern is changing to the NCD. 70% of your contribution or the disease pattern is coming from the NCDs, right? So home care, I think that's something very important. It would grow at 15% every year. So this is going to grow the way, because you don't have to, because there are a lot of services which would be provided at the home care. For example, pain and palliative care, even for other diseases like diabetes and cardiovascular, there are home care services would increase. So I think this is a very important time. I think we are at the brink of an opportunity there where we should ensure that the carving out, like Krishnan sir had made, we have to carve out those areas where this would not have even more cyclic effect. I think when I was making this statement from the beginning, these tertiary care is something where it is something offloaded from the general. It's highly skewed. The OOP is highly skewed. I think that necessary care should be taken that the home care is properly delivered, and also the costings do not improve or go cyclic way, so that there's also a business opportunity for many people. So this business opportunity should not be shut down just because the cost will go high. So I think that's the simple statement I would make.
Thank you so much, sir, for your inputs. We have another question from the audience for the panel. It's whether GST will be applicable to HD or high dependency unit which functions as step down ICU. Would anybody like to take this?
Yeah,
Mr.
I think it is subject to, because it's a medical device. So all medical devices, I think they pay a standard rate of either 12% or 12% or 18%. So they would be subject to duty. All the medical devices are subject to duty now.
Sir, if I may interrupt, I heard the HDU is high dependency
HDU,
unit.
exactly. That's what I wanted to say
like
also.
An acute medical ward.
Mr. Krishnan, we have in a hospital, regular hospital rooms, and we have ICUs. In between, we have HDUs, high dependency units. So the question is whether HDUs, where the charge is more than 5,000 a day in terms of the room rent, whether they would also be charged GST or not.
I mean, it would appear so, because a specific reference has been made to ICU. So logically it would be charged, because the terminology, when anybody interprets the law in the field, a taxation man, ICU is ICU. So bringing in something else within ICU, unless the government issues a clarification that for our purposes ICU also includes this, it would be subject to duty and outside the exemption.
Thank you, sir, for your inputs. I would now request Anugrah to please come in and let us know if there are more questions or aspects that the panel would like to discuss.
So thanks, Shambhavi. There was a question asked on the room rent. Is that been answered?
Yes. It was the first point of discussion with the panelists, the room rents.
Okay, thank you, Shambhavi. So there are no further questions, I guess. If Dr. Mahajan and Mr. Barua, if they want to ask something.
I think we've had a great discussion, tremendous inputs which have come in. And I think, Anugrah, now it's up to you and EY to actually collate this. And some very searching questions have come. I'm sure no one thought of HDU when, the room rental or the kind of rooms were, discussed. And so these are some clarifications also that can be asked of the government, of the GST Council. And HDU personally is different from a room and should be clubbed with ICU. But as Mr. Krishnan said, unless it's there in writing, it'll also be taxed. So I think a lot has come out of this discussion. Thank you very much.
So thank you, Dr. Mahajan, and I think indeed great inputs. And I am very much sure that with this discussion, we may have to, compile what some of the engaging discussion points which have come out. And I really thank all the experts here and the EY team for this enriching panel discussion. With this, we are 3 minutes early, but with this, we are about to bring this workshop to a closure. The event has brought together industry experts to help chart a way forward for the GST regime. Once again, I would like to thank everyone for joining us today and making this event a resounding success. In case you have missed the session, the recording of the session will be available on our YouTube and FB channels. If you have any further questions, you can write to us at secretariat@nathealth.co.in. Thank you, everyone, and wishing you all a safe weekend ahead.